and Bellevue Clinic, and that's where we do a lot of our practice. Now, there are two divisions of what I was asked to speak on. How do you select a candidate for bariatric surgery, and then what are the nutritional implications once you've selected them? Now, you will be surprised that you would expect a nutritionist to have written the first book on bariatric nutrition, correct? This is in 2014, and the first book on bariatric nutrition was written by me, and I released it here in Calcutta. This book was circulated free of cost around the country amongst centers which were doing bariatric surgery. For about 4-5 years, there were no other books in at least our country or in Asia. But then me and my friend Aparna, we wrote this book on management of nutritional and metabolic complications of bariatric surgery, and we edited this book. We had chapters from eminent people across the globe. And this is something that is very prevalent now. And now coming to, you are all managing patients with obesity. Who are your patients? So who do you select for bariatric surgery? Who do you send? Okay, I will not do this anymore. I've tried this patient on various dietary measures, but now I want to send this patient to a bariatric surgeon. And this comes from the guidelines, which are the latest guidelines published in 2024 September. So this is hot off the press. And what this did was this based on the data, high level data, and in those areas where there was no high level data, they chose Delphi consensus amongst the experts. And the question was, whom do you offer bariatric surgery? At what BMI? So people come in different shapes and sizes, but as you know, one of the major things that we look at is the BMI. Of course, BMI is not the great indicator, we'll come to that as well, but BMI is approximately the best indicator, which is simple and easy to use. So the old guidelines were in 1991, and there it was said BMI more than 40, send the patient for bariatric surgery. BMI more than 35, along with one disease like diabetes, sleep apnea, send the patient for bariatric surgery. This guideline, this is level 2 evidence for this, that the patients with 30 to 35 with one disease like diabetes and sleep apnea, send at least and recommend at least or suggest at least that this could be a problem for bariatric surgery. The other thing was that for patients with 30 to 35 who are not losing weight on nutrition, on dietary measures, even those should be sent. So you can see the drop is huge. In BMI points, you have reduced from 5 to 10 points. And if somebody's got a BMI more than 35, regardless of any disease or not, so right now we're talking about 30 to 35 with diseases or unable to lose weight, both categories. Now we're talking about more than 35, irrespective of the disease, you can send. But look at this level. The level of evidence is level 5, which means only experts think so. There is no data to sanctify this. What about diabetic patients? As you know, bariatric is now called bariatric and metabolic surgery, MBS. And why does it work very well with diabetes? Not only because of weight loss, but because of other mechanisms that we will not touch today. But if the BMI is 30 to 35, along with diabetes, it is recommended. And that comes with level 2B evidence, which means a very high level of evidence and data is available for patients of this category. In Asians, we have redefined obesity. It's not BMI more than 30, which is obesity, which is BMI more than 25, which is accepted as obesity. So that is again endorsed in this. A lot of our people come and say, you know, this patient is 65, is she too old? He's 70 years of age, but he's 130 kilos. He's probably too old for bariatric surgery. True, but the concerns of complications, death, and all the nutritional supplements that will come with it is true. But when you look at the evidence and amongst people who have been treated, it is not the age which is important. It is whether the patient is a smoker, has an end organ disease like a heart failure or a cirrhosis or a respiratory COPD problem. And what is the cognitive capacity? Is the patient intelligent still? Those are the points to be understood, not the age. This is a lady who used to play golf in Tolleyvinge Club. And because of the weight, she lost her capacity to play golf. And after the surgery, she started playing golf and she won the championship. It's not a tribute to the surgery, it's a tribute to her and her effort. This is a boy who was 16 years of age when he saw us. He locked himself in the room for 2 years He had become diabetic, he had sleep apnea, he had very low self-esteem. He had locked himself up for 2 years, he would not go out to meet anybody. In this patient at 16 years of age, the parents of course were not thinking of bariatric surgery because they were told that the skeletal maturity will not happen, the bones will not fuse, there will be pubertal growth will be hampered, he will not be having a good sexual activity later on, and there are so many complications of bariatric surgery. What if it leaks? If you look at the guidelines, one thing is metabolic surgery does not negatively impair the pubertal development or the linear skeletal growth. So the height is not going to be stunted, sexual activity is not going to be altered. At an age of 14 to 18 now, it is allowed and it is actually recommended to do this surgery because there can be permanent emotional scarring and some patients can actually become permanent diabetic cripples. And that comes with a level 1B evidence, which is what is most important. Data is in favor. And this boy we operated at the age of 16 years, and at the age of 24 years, 8 years hence, this boy is a successful real estate owner along with the fact that he's a marathon runner. So this is not again something that you see was one isolated example. There are many examples. This is a lady who came in a wheelchair. She couldn't walk. The orthopedician advised her knee transplant. But she also had significant COPD, respiratory problems. She couldn't walk. Her heart was a problem. And obviously, it is very difficult to operate BMI more than 60. These are we used to call them super obesity. Those words are not accepted anymore. So what do the guidelines say? The new guidelines, they say safe and effective. Yes, there is a higher rate of complication. But if somebody's really got the back against the wall, why not? And this patient about 4 years later after the surgery went on a world tour where she roamed across the globe. Now, many patients are like this. They have a huge hernia and every time they have a hernia surgery by a surgeon, it fails. Obviously it will fail. Obviously it will fail because you've not addressed the major problem, which is the obesity. So what do? What does the guideline say? Well, do the bariatric surgery first, then do the hernia surgery. So we did a sleeve gastrectomy on this patient, and then she lost about 35 kgs over 10 months. Then she looked much less ominous, and then we went ahead and did the surgery. So if you look at the before and after the bariatric surgery, this patient went from obesity and hernia together. We tackled the obesity, then we tackled the hernia, and now she can live comfortably. What about patients with cirrhosis? When you get these patients with cirrhosis and they're going to have a liver transplant, when they're or a kidney transplant, when they're BMI more than 40, it's very difficult for the surgeons to operate, and these grafts are also difficult to survive. But they can have a bariatric surgery now simultaneously or prior to the transplant to get better. This is the kind of liver you would see. I am sure many of you have not been into the OR, but you can see that the liver is huge. And I want you to have a pictorial image of this liver is because you do not realize what is happening. Many of us will not realize unless you see it. This is the kind of liver that the patient is already having. And if you do not address the weight loss promptly, you allow it a year or 2 or 3 years, patient has gone to a liver failure and the patient is probably not going to even make it to the liver transplant table. So doing a surgery may give this patient a better chance. Anybody with a knee pain waiting for a arthroplasty, and if their BMI is more than 40, do think that these patients would first benefit from a weight loss, whether it's medical, nutritional, or surgical, and then only undergo, because it's been seen, even the orthopedic societies are now saying, based on data, that they will not do well unless they are tackled with weight loss first. That brings me to the end of the first part. What are the patients you are sending for your bariatric surgery? The next part is what is hardcore nutrition. Let's say there's a patient who's been a candidate for bariatric surgery and now has been referred to you. You have to now see whether you will tell the surgeon, yes, go ahead with the surgery, I've understood the patient. What are you going to understand about the patient? Let's go. First of all, your nutritional assessment is crucial. You are the person who will allow the surgeon to operate. You can say, not cleared, and that's how it should happen. And what are you going to see? So what does the bariatric surgeon want from you? Obviously, he doesn't want you to scare the patient, but he or she definitely wants you to optimize the patient and tell him or her what the patient is all about. So know about the calorie intake of the patient. You will have to know about the protein intake of the patient and tell the surgeon, well, you see this patient is a very high carbohydrate eater, very big volume eater, or has a binge problem, has an emotional eating, or a night eating problem, is a snacker or a grazer. You are the person who's going to tell the surgeon all of this. The surgeon may alter the procedure. The surgeon may defer the surgery. Also, you have to tell the patient, the surgeon, whether the patient is having addictions to sugar, colas, alcohol. All that is very, very important for management. And there's one part which is called nutrition education. No matter how much we say within these two words, it means a lot. What it means is that you are preparing the patient for what is coming after the surgery. And we call it weakness. Water. Patient will forget to have water. You have to tell them, please remember to have water after your surgery. Your stomach is small. You have to remind yourself. You have to exercise. It is not an alternate to exercise. It is just a supplementation. You have to eat slowly. So that practice begins from prior to surgery. You have to start educating them, eating slowly, chewing slowly, not combining food and water together. And they must know on a plate, where is the protein? If they cannot identify where is the protein, you have to educate them where is the protein, both vegetarians and non-vegetarians. And you have to tell them that the simple carbs, the processed carbs like colas and sugary drinks are going to be detrimental and give them dumping syndrome. And you have to educate them that they will be taking supplements, bariatric supplements, which will cost them about 3,000 to 5,000 rupees every month. And that has to be known. And finally, a lot of support. If you look at the supplements which are over the counter versus bariatric supplements, you will see a stark difference. A bariatric supplement is typically 2 to 3 RDA. And I'll come to that why. And over the counter supplements will not furnish you at all that kind of thing. If you look at vitamin B1, it is 1 to 2 milligrams and over the counter, but you require 12 to 50 milligrams of vitamin B1. If you look at vitamin B12, you will get 6 microgram approximately in over the counter, but you require 1000 microgram in the bariatric supplement. If you look at the iron, calcium, vitamin D, everything, everywhere you will find that there's a stark difference. So the money has to be spent, and they should need to know. As a preoperative optimization, you have to make sure the liver I showed you, it's so difficult to suture, right? If you can shrink the liver by a 10-day low carbohydrate meal, it will really help the surgeon in doing the operation. So it's your job to give the patient a meal replacer and make them into a low carbohydrate, high protein diet before the surgery. Also, many of the patients with obesity will have vitamin D deficiency, iron deficiency, and these deficiencies try to correct them prior to the surgery. Once there is a GI alteration, orally you will not be able to rectify them. So rectify them prior to the surgery. So these are the hardcore job of a nutritionist. Now you've done the surgery, and now you have to follow up these patients. What are you going to follow up? So what the mind doesn't know, eyes cannot see. Right? You need to know. Your knowledge has to be there. I'm going to furnish you with basic knowledge today. It's an extensive subject. This is based on the IPSO guidelines as well as BOMS guidelines as British, also from societies like American College of Endocrinology and anesthesiologists and so on and so forth. So basic science is we have 3 major procedures in India: sleeve gastrectomy, room-wide gastric bypass, and a mini gastric bypass. And in these 3 surgeries, what you need to see is the first one does not alter the GI tract. So it will alter your nutritional problems less. Whereas the other 2 are going to alter the absorption. Now, causes of malnutrition. Why you will have nutritional deficiencies after bariatric surgery? Well, you're rerouting the GI tract. So A, there are pre-existing deficiencies that may not have been corrected. That's number 1. Number 2, if your surgeon is in a hurry, that the first point is very important. Thus, number 2 is restriction of food intake. Every bariatric surgery will allow the stomach from A size to A, 25% of A. So it will just be 1/4 or 1/5 of what the volume is. 3, there can be taste alteration. You may develop distaste to what you used to eat before, like meat. Hypochlorhydria, there's a reduction in hydrochloric acid. So the absorption of your iron and your protein and B12, they can be altered. There's lack of exercise and sunlight in many of the patients prior to surgery because they have locked themselves inside. Maybe that is not corrected even afterwards. So that has to be corrected. Otherwise, the vitamin D deficiency, bone health will prevail. Reflux and nausea may be a side effect to this problem. So therefore, you have to identify these patients and then treat them. Some patients may have diarrhea. Very few. But malabsorption is what I have written in the bottom. That is the duodenal and jejunal bypass. If you look at what is done in the bariatric surgery, if this is the stomach, duodenum, jejunum, ileum and colon, and if you're bypassing the duodenum and the jejunum, what you're bypassing is basically the nutrient, your macronutrient like amino acids are absorbed in your jejunum. Naturally, there will be protein deficiency if you do a gastric bypass. Number two, your calcium and iron are absorbed in the duodenum. Therefore, these deficiencies will be there. And if you look at the B complexes, they're absorbed in your proximal jejunum. So your B1, B2, B6 deficiencies will be there. And how do you circumvent this? You circumvent this by passive diffusion of these macro and micronutrients by giving them 2 to 3 RDA. That's the story. And this is something that now you will start understanding. Only if you do very bad diversionary procedures where the limb bypass of the biliopancreatic limb is huge, you can get vitamin A, E, K deficiency or essential fatty acid deficiency. Vitamin B12 is a peculiar vitamin. It's a water-soluble vitamin, but it's not absorbed in the jejunum. It's absorbed in the ileum. It has an intrinsic factor in the stomach. It's an atypical vitamin. Therefore, vitamin B12 deficiencies can happen also irrespective of the procedure. 4 deficiencies is what you need to know. Protein, there's no carbohydrate deficiency, rarely fat deficiency. But protein deficiency, yes. Iron deficiency and anemia, calcium, vitamin D and bone health, and B12 deficiencies. We'll quickly say, then generally in a sleeve gastrectomy you will have much lesser deficiencies. In a bypasses you will have more. Weakness will be a common complaint, so you have to investigate. And number 3, the problem will be more in vegetarians in terms of protein deficiency. And finally, if you get one deficiency, the patient probably has another deficiency also, because deficiencies go hand in hand. This was a paper that we published. It's called Dampen. It's a mnemonic. If you have somebody complaining to you with weakness after bariatric surgery, this is the cause. Dehydration, dumping, anemia, autonomic insufficiency, micronutrient deficiency, psychological, that is 30% of the entire cohort, protein energy malnutrition, and neuropathy. These can be the cause of weakness. The patient may say weakness, the patient may not mean weakness. You have to understand what it is. Protein deficiency will be important because 1 to 1.5 grams, which means 60 to 80 grams, having somebody to ingest that much is very difficult. If they do not consume it, they have weakness, alopecia, edema. And alopecia is pretty common, but it's transient, it comes back. But if you do not follow these patients well, especially gastric bypass, they can come to you with severe protein and energy malnutrition. Even at 3 years, only half the patients can consume 60 grams of protein, which means the nutritionists can do better, the patients can do better, we all can do better. Now, when we measure the limb, if you don't measure it very well, then we can have problems. We can have a higher deficiency because what we thought was 150 centimeter were actually 200 centimeter bypass. Make sure that your surgeon knows how to count. Well, check the patient with their serum albumin, body weight, but most importantly, I will emphasize here, please learn how to use the body composition analysis. This is the kind of machine that it is. If you look at only body weight, this is our paper that in 10,000 patients, this is how the weight reduces over 1 to 5 years. But that doesn't tell you about the body fat and fat-free mass. It's important to know that after almost 20% of the weight loss is because of the muscle mass. And the maximum permissible is about 22%. So if you have a graph like this and you find here 157 to 135, 22 kilos, but the muscle mass has gone from 42 to 35, that's 7 kilos. This is unhealthy weight loss. This is more than 20%. If it is mild, you can treat with dietary changes and protein supplements, but if it's severe, admit the patient can die. Iron deficiency. Iron deficiency again has a lot of cause, but very frankly, always remember this algorithm. Must look at the patient whether there's having a microcytic anemia, megaloblastic or normocytic. If it is microcytic, ask if the patient is having more periods, more bleeding in stool. That can be the cause, not the bariatric. And if it is not there, then iron deficiency anemia is the commonest cause of microcytic anemia. If it is not there, then think of copper. But if it's a megaloblastic, simply think of folate and vitamin B12 and supplement them. Normocytic, many of these patients will have liver disease and kidney disease. They will have normal cells RBC anemia. These are the patients who will require a physician. Some patients, despite your oral iron, and this is our paper that we submitted about hepcidin. You all are sensitized to hepcidin. Unfortunately, the surgeons that I talk to are not sensitized to hepcidin, but you all are. So if the hepcidin is abnormal, then the oral absorption of iron will not take place. Therefore, use intravenous iron in refractory anemias. What about calcium and bone deficiencies? Well, again, in gastric bypasses, it's far more than the sleep based on this paper. It will lead to low back pain. But see here, what you have to measure. You are measuring urinary calcium, alkaline phosphatase, vitamin D, parathormone. You are doing bone scans. But did I measure, say, serum calcium? No. Serum calcium is not a good indicator for total body calcium. That's why I'm not mentioned. You must treat them with calcium citrate and keep the vitamin D more than 50 so that the calcium is absorbed. Vitamin B12 deficiency, again, can lead to anemia, weakness, fine, but it can also lead to neuropathy. And if you don't treat them early, they can go into irreversible neuropathy. That is why I put this slide here. Although you will measure serum into vitamin B12, in many cases they will be normal, but you have a strong suspicion this is vitamin B12 deficiency, you must do serum methyl malonic acid. So, you must not treat these patients of B12 deficiencies with oral because they will not get absorbed in bypasses. Use nasal spray or you use injections. And that brings me to the end of my discussion and presentation. There are some rarer complications which I put here. They do not happen in more than 1% of patients, but that's something just to be remembered as an academic exercise. Take home message. The NIH guidelines have been replaced by the new guidelines. Please look them up. The indications have changed. And it has been said that the most important part is adequate nutritional supplementation. Everybody agrees on that. So you all have a huge role to play. And if the patient has a bariatric surgery, then supplementation and surveillance by a registered dietitian is important. It has to be lifelong. And we are not talking about the surgeon being the captain of the ship, but rather the multidisciplinary team being the main focus of the entire treating team. Thank you very much. I'm sorry I've exceeded time.
Thank you so much for such a beautiful presentation. Please take your seat and any questions to